over in the Watts South Side area, and worked out a plan where we would hold clinic there 2 nights a week, a mental health clinic in the church. And he set up the basement, and people came. We opened and they came. And the reason why they were not coming to UCLA, it was far away, no one welcomed them and so on, and they felt safe within the church, and this was also being endorsed by the minister. It was my first example about how you have to hook up and collaborate with people to do things in innovative ways, and it's very doable, except a lot of us don't like to go away from our centers and habitats to go out to help people on their own turf. Part of the title of my talk tonight is the legacy of Tuskegee and healthcare for African Americans and so on. Let me just say straight out that Tuskegee study, if you compared it itself in terms of its importance or the gravity of its horror, I don't know if it would rank that high. You have to think about all the other things that they have done to black people. I mean, just, it was part of what they did. If you go back and just look at slavery, I mean, reports say that before they got the slaves on the ship, maybe 50% of them died from violence and all kind of things. You put them on a ship, about almost another 30 to 50% died from all kinds. You put them in all those kinds of diseases and so on, they were dying. And then they brought them here to the United States, and then they were exposed to, talk about Tuskegee studying syphilis. The Africans didn't have any syphilis. They got it when they came to America from the Europeans. You see, so they started getting, plus they brought other things like yellow fever, malaria. So the question of there not being any health care and disease and trauma and death from disease and from neglect, I mean, it's just enormous. I mean, it's not even fathomable. I mean, we like we're into some kind of denial, you know, like when they said Jefferson, you know, had this slave woman that he, you know, was his honey and stuff like that, and had children, people say, oh, no, that couldn't, oh, no, no, no. I mean, give me a break. I mean, you know, probably all those white men slept with black women. What black women had no rights. If they wanted it, they took it. You understand? We are not these different colors because of anything black men were doing with white women, right? We are all these different colors mainly because of that, and that was exploitive, abusive, and it was often, and it was rape. But just think, one of the questions that I think affects, you know, healthcare. Let's put it another way. What was your life worth as a slave? What was your life worth after slavery during institutionalized Jim Crow segregation in the South for another 100 years? I mean, by definition, black lives were not worth very much in comparison to white life. So there's 2/5 of a man or a woman, but worse with the woman in terms of counting in a lot of ways. So our lives didn't count very much. Now, if you just take that and look even in terms of the civil rights struggle, it's been to make our lives count as much as a white life in America. And this affects other minority groups too. And you can ask yourself the question right now to yourself. See what kind of, do you think a black life in America counts as much as a white life? And then look at all the institutions and how they function in relationships to blacks. That there's evidence after evidence after evidence. The criminal justice system isn't fair. Anybody who investigates that tells you. The death penalty, I mean, the death penalty back the first time before they stopped it later on, every man electrocuted in the electric chair for rape was a black man. And it was for raping, so-called raping a white woman. White men didn't go into the electric chair for raping black women, because what they did with black women was not rape. They never got, that wasn't illegal. And then white men didn't go to the chair either, if, you know, if for raping black women, but also if they did go to the chair or get the death penalty, it was always, the victims always have to be white. And that's still a pattern today in the criminal justice system, not to mention all of the inequities in sentencing, the cocaine with the crack, and the fact that studies show that for black men who commit the same crimes as the white man, they get stronger sentences. So look at any institution. Now look at health. You know, the bottom line for racism is what? So we have to remind ourselves, racism, unharnessed, is genocidal. If the premise is that racism has components in it that are genocidal, and then look at the healthcare system, wouldn't you expect, just like in a criminal justice system, it would be expressed in a healthcare system in terms of the value of your life, the value of your life, and that in health care, medicine, it's a life-death matter. So if they give you lousy care or no care at all, you're more likely to die. You see, that's the element, you see, that's similar to someone just murdering people, but it's by commission and omission or just not caring that then becomes institutionalized in the system. Now, talking about doctors, well, let's realize that the healthcare system basically, except for a small bit, was controlled by white physicians in this country historically. Okay? That means all the attitudes they had toward blacks were being played out in different kinds of ways. And they were part of the group, many of them, in fact, who preached the inferiority of black people. Physicians were in on that too. I mean, one of the whole weird things with Tuskegee study, they had all these strange notions about potential genetic differences in blacks and whites that was going to make the syphilis maybe more virulent, and they had to see the natural course of disease. They had all kinds of notions about differences based on race, a lot of them stereotypes. And it always used to puzzle them that blacks didn't have, black suicide rate is only 1/2 the white rate. But I don't know if I believe that. And they say this goes back to slavery and after slavery and so on, because they had a reason to keep the suicide rate down for black people, because it would look like slavery was benign. Do you understand what I'm saying? That slavery wasn't so bad. Look, black people weren't going to kill themselves. And some of them used this argument when they were fighting to maintain segregation. They said, you get those black people get in the mainstream, their suicide rate's going to go up. You don't want that to happen, so this is like the best of possible worlds for these folks. So now let's go back to the 1850s, because I think it plants a seed of what I think is a profound thing we all have to understand about all of this. And that's the story of Dr. Cartwright, Dr. Samuel Cartwright, who was called to a plantation in the late 1840s in Louisiana because slaves were running away from the plantation to freedom and escaping to the north. And this slave owner was upset because he was losing his property and his profits. So he called in Dr. Cartwright, who kind of was a surgeon who doubled as a psychologist and had a big rep for understanding black folks, right? So they call him in for his expertise. I mean, we have people like that still today who can, become experts. You have to watch what their perspective is and how they're coming at it. But he came down and he did what social sciences would do today. Talked to everybody, the slaves, the overseers, and everybody in plantation. And then he wrote a long paper. The paper was published in the New Orleans Medical Society Journal in 1851, a long scholarly paper. And I have it in my files, the whole paper in my file. You can go from the journal. In the paper, Dr. Cartwright concluded that the slaves who were running away from the plantation to the north were suffering from a mental disease, which he called drapetomania, which means runaway mania. And then he said other slaves were suffering from another mental illness because they were belligerent. Right? Now think of what he's saying. That, I mean, it sounds far-fetched and wild now, but actually, in his context, it was normative kind of response. What he was saying was that slavery was the best of possible worlds, and deviations from even the slaves wanting to get away from slavery was psychopathology. Now remember that, whatever your perspective is and whatever you're defining, and then what you define as psychopathology, has to do with a lot of perspectives. It's not a hard science. So he was saying that, and it was a way also of legitimizing slavery, and also making all the slave owners feel that slaves who ran away were crazy, so they were doing the right thing and keeping them, chaining them, and all kinds of other things, and brutalizing them, right? It legitimized. Then I know there were some black people who were indoctrinated too, because black people hear the lie that they're inferior and so on and so forth. So I bet back during those times, after Cartwright gave his paper, that when some slaves were trying to run away, there were other slaves saying, "What are you trying to do? You stay here. What are you, crazy? Stay on the plantation." Because they get indoctrinated too. And that's still one of the issues today if we look at the experience that we've been through psychologically. If you look at the experience psychologically we've been through, just close your eyes and appreciate for 250 years of slavery, the constant indoctrination was that black people were inferior. They were subhuman. 250 years of that. And then another 100 of Jim Crow segregation legalized and accepted by the United States government doing the same thing. 350 years. Ask a rhetorical question. How long does it take to get over that experience? And the same question you can ask, how long does it take to make up for the inequities and the disparities in health care for black Americans that started way back during slavery, in which some public health researchers at Harvard who are black have called the slave health deficit, that you can trace it all the way back. I mean, Tuskegee's study, they were doing experiments on black people all the time because they saw black people as being available for that. And they weren't just doing it in the South, they were doing it in New York and all over the country. We didn't, we have this informed consent. Informed consent is relatively recent. That's like maybe 40 years old, 1960s. Informed consent, where you tell the patient you're doing research. Before then, you came in the hospital and they did what they wanted. And Fannie Lou Hamer used to be not fond of, but used to talk about the Mississippi appendectomy, which was a sterilization procedure. They would take out black women's uterus and so on without even asking them. They did all kinds of research on, a lot of it probably unpublished or published places, and people dig it up. They did things like try to bury people and all kinds of things. There was a study I discovered in 1963 in Texas where they took black babies and decided to see what effect withholding one of the essential fatty acids from their formula would have on them. And their skin got all scaly and all kinds of things. Even a number of them died. What's weird thing is they had done this study before on dogs and then decided to see if they can do it on human beings. Now, one thing you have to know that in terms of ethics, morality, in the medical world, you never do research where the outcome you're looking for is supposed to be negative, is supposed to be harm to the subjects you're researching. That is always bad research. That's why the Tuskegee study was bad research on the face of it ethically, because people were being harmed by it. You can't do research in that way. But before informed consent, people did what they wanted, and that was the way it is. So black people coming from this tradition, let's take a look at it. Until 1965, 1966, hospitals were officially health facilities segregated throughout the South. And their own way, they were segregated in the major cities by neighborhoods and so on. And blacks used to go to the public hospitals, you know, and so on. And that's where they went. In New York, they went to Harlem Hospital. Even though you had Cornell and Columbia sitting up there with those mansions, they went to Harlem Hospital. And blacks then became afraid of their own hospitals because they thought they weren't as good as the other ones, or they had broken down buildings and all kinds of things, so it gets very, very complex. But segregation, segregated medicine is an oxymoron. It doesn't even make sense to say you have segregated medicine, because segregated medicine meant that black people were getting no care or inferior care. And let me tell you something about the mentality, because it would blow my mind. When I was working in Mississippi for about 2 years, and one of my jobs was to deal with getting places desegregated, the hospitals. And I would go into the hospital to talk to the white chief officer, the doctors, to tell them we're here to see they have to start desegregating because the laws had been passed. But they weren't desegregating, even though the laws had been passed. They were going to keep it that way. And I would go in and they would invite me in. They were very nice to me, offer me coffee and cookies and stuff. And we would sit down and talk. And what it would amount to, this doctor being very nice to me, running the hospital, was to try to convince me that the best care, that the black people got the best care that they could get under segregated medicine, and that it was actually good for them, this system of care. Now, you can walk on wards, and you could see the black side with the peeling paint and the broken equipment and the torn blankets and the unswept floors and a little bit of staff because they were all on the white side. And you knew that people were dying because of segregated medicine. They were dying. And if you happen to be in an area where the hospital was all white, which was also against the law, they were supposed to have segregated stuff. So they designated some hospitals all white, and if you came there, let me tell you, they did not take you in. And that's one of the reasons why you had a lot of black folk healers all over the South, root healers and the midwives, because if a black woman came to a white hospital, say in Yazoo City, Mississippi, which is about, I don't know, 50 miles or something from Jackson, that was an all-white hospital, and they wouldn't take them. So either they had to have midwives to deliver them, or they had their babies in cars or trucks trying to get down to Jackson to get to the segregated hospital in Jackson. So that, think in terms of segregation in medicine, that you had to, every time you went in for care, you had to trade your dignity and reinforce the image inside of yourself that you were worth less as a person compared to a white person every time you made that exchange. And then what did you think, or what would you feel about how that doctor who practiced segregation valued your life? Now let me tell you, it was not from some activist movement on a part of white doctors realizing that they were en masse violating the Hippocratic Oath. It should have been the hypocritical oath for them. But they were violent. There was no mass uprising, and they're saying, this is awful, and this is killing people, and people are dying because of this, we have to change. It didn't come from doctors. It didn't come from the American Medical Association. The American Medical Association would not force and push the Mississippi Medical Society, which was part of the AMA, to take black doctors. They wouldn't do it. They kept saying, our chapters have autonomy. Autonomy to practice segregation and to let people die and be sick. See, it didn't come from them, and I think that's what we have to know. Because we're talking 35 years ago. It didn't come from organized medicine. It didn't come from the doctors in the South. There were doctors around who joined the movement, but it wasn't because of doctors, it was because of the law and the civil rights movement that it's changed. But it wasn't even high, and we have to ask ourselves some questions about this. Why wasn't health care, segregated health care, high on the agenda of the civil rights organizations? It was not. They had lunch counter, they had voting, which is very important, they had education, but they didn't have a critical life-death issue on the agenda. None of them did. SCLC, SNCC, CORE, NAACP, they did not have it high on the agenda. And I can't figure it out. Is it because it's less glamorous? Have you ever seen the civil rights organizations picket and demonstrate against a segregated hospital in the South or Mississippi? You never see it. So what does that say about where it all fits with us? And does that have something to do with some of the disparities we have now because we have not been activist enough around healthcare issues, and have it been too passive in relationship to the kind of services that we get, or that we receive. Now let me go back and tell you another story. My psychiatric colleagues had an all-white facility too, and they wouldn't admit black patients. So I was trying the old technique of being a nice Negro, and they would see that I was such a nice Negro, they would let blacks into the facility. So I would go over there and give grand rounds and smile and stuff, and all this stuff. And all these people would like me. He's an intelligent Negro guy. And, well, of course, that doesn't work, right? I mean, that's simple-minded. But a lot of us used to do that in the past, that we would set an example. We would go someplace as the one person and show that we were so wonderful that they would just love all black people. Well, it doesn't work that way. Anyway, they didn't want to, after all of this, it came time for them to desegregate the psychiatric unit. And they sat around and had meetings of social workers, psychiatrists, and then held kind of a press conference and said they believed in democracy and equality, but they felt that to desegregate their psychiatric unit at this time would be detrimental to the mental health of both blacks and whites. Sound like Dr. Cartwright, don't they? 1965, it sounds like Dr. Cartwright. So it ain't an academic discussion. You don't get an academic discussion with Dr. Cartwright. You say this man is a racist fool and he's your enemy. And he's trying to do harm to you, and there's no reason to be sitting down having nice discussions with someone who's doing harm to you very actively. Well, that's the same with the Mississippi psychiatrists at the hospital, because what did their position mean? It meant that they took a position that would maintain the status quo. They still weren't going to accept black people because they were concerned about their mental health, which is bizarre and just twisted. But that was the argument they used. So the law came in again, and we sent in complaints, and they were threatened with having the federal money taken away because they were still an all-white hospital, and they started admitting black patients, and we monitored them. But I'll give you a little puzzle. You'll figure it out. I'm not going to give you the answer. After we monitored them for about 6 months, we found they were admitting black patients in token fashion. And all of the black patients they admitted were black women. Now, you're to figure out why they were not admitting black men to the psychiatric unit at this hospital in Mississippi when it first was desegregated. Another story I want to tell you, I think is very, very important one, that describes difficulties in terms of the black community and in terms of seeking out and trusting the healthcare establishment, that was much more profound than the Tuskegee study itself. Even the Tuskegee study, because it got a lot of publicity, added some fuel to that. But it's the whole experience we've had as a people with the healthcare system. Well, anyway, there was a hospital up going toward the Delta in Mississippi that we really went after because it was just boldly segregated with white and colored signs still up. So we got the federal people the things you had to do and got the signs taken down, and the hospital was supposed to desegregate, and it wouldn't be a separate colored and white waiting room and so on and so forth. Well, we went back about 3 or 4 months later, and we walked into the hospital to the waiting room, and what do you think we saw? All the black people were still sitting on the color side, and all the white people were still sitting on the white side. There were no signs up. So we waited outside, and we grabbed some of the black patients as they came out. And we said, you know, you don't have to sit on the color side anymore. You can sit anywhere you want. And they looked at me as if I was insane. Like, what are you talking about? Now, they were right. See, they were right. And here's the way they explained it. They said, you see that guard over there? The guard? Security guard? They said, you think he changed his attitudes since the signs were taken down? And then they said, do you think the doctors and nurses have changed their attitude and now are not racist because the signs are taken down? They said they didn't think so. And that they felt that if they sat on the white side, the white doctors and nurses would retaliate against them by not giving them health care or letting them die. That's what they said. Now you count that experience all over, and there's people today who don't want to go to hospitals because they think people are going to let them die or people are going to do research on them. I got an older sister. I can't get her to doctors. Every time she go to a doctor, she's worried about research being done on her. They give her a pill, and she calls me up and says, is this some experimental medicine they give me? You know, everything, because the distrust goes very, 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 very deep because of a host of experiences, not the Tuskegee study, and because a lot of black people know and sense they didn't get good health care. They knew they couldn't become doctors and all kinds of things. And then even in major cities, they got the worst of the health care. You know, so we talk about cultural competence now. You know, people complain about, you know, things that happen. Some people say, like, the cultural competence, why don't you just teach them to be nice? You know what I mean? Because you go to a lot of places and people don't act very friendly. And if you're poor and you're minorities, they may act even less friendly because there's power relationships that exist. And so part of the cultural competence is getting rid of some of the unconscious or conscious negative attitudes that healthcare personnel have toward minorities and poor people. Same way they may have them toward the homeless. And doctors, if you talk to doctors, they will tell you, they will always tell you, the ones in Mississippi didn't think they were prejudiced, no matter what they're doing. Some knew they were segregationists. But they're going to tell you they're treating everybody the same. But if you do research, you find they're not treating everybody the same. If you take videos, you see they're not treating everybody the same. Some people, they say hello to and good morning, and some people they don't. And some people, they shake their hand, and some people they don't. And some people, they say, take a chair right over there, I'll be right with you, and some people they don't. And then there's all kinds of body language, facial expressions, right? And so people pick these things up, and black people got long antennas. And they have more than their share of distrust. Or maybe that's not the right way to say it. Maybe they have the proper share of distrust. And they have paranoia. You know, black people are overdiagnosed for paranoia in mental health clinics. Because, you black man, black women, you walk in and you start acting suspicious because you think you should be suspicious. And they say, oh, suspicious. Paranoid. And then if you start asking provocative questions, they put down paranoid, hostile. I mean, you start getting the stuff. And that's a neat one, like paranoid, schizophrenic, because they can still involuntarily hospitalize you much more easily. You see what I mean? Now, we're underdiagnosed for depression. And I read papers a long time ago where they were saying black people don't get depressed as much as white people and everything. And in one of the discussions of the paper, one of the doctors speculated it was because we were happy-go-lucky people. And that's a true stereotype, that we're happy and everything just rolls off and we don't get depressed. Well, it's interesting, black people don't think they're depressed either. If you ask them if depression is a health problem, vast majority say no. They don't see depression as a health problem or as an illness. Well, figure they don't consider it an illness, but black people invented the blues. Now that's an interesting cultural kind of twist, isn't it? They felt they were born to suffer. So if you think nobody knows the trouble I've seen, nobody knows my sorrow, and that's the way it is, your whole scale for misery, your misery index is different than the misery index for, say, a typical white person, right? So you may not consider that to be something that's, quote, an illness or a disorder. But blacks suffered from a lot of depression. Another thing, you want to see the legacies of Tuskegee or distrust. 70% of black patients who are depressed say that if a doctor gave them antidepressant medications to treat their depression, they would not take them. Okay, they wouldn't take them. So all these medicines people giving out, they have to find out why people aren't taking them, right? And you can explore that. It will be different with different individuals. Some will be research. Some of them will see the doctor giving them the medicines as a rejection. You see what I mean? That is, you don't want to bother with me, so you give me these pills, and you're not really listening to what's going on. All kinds of complicated reasons. And then the other problem is, like, you know, psychiatrists and psychologists and people, they're so interested in psychopathology. I mean, people come in, I mean, even if they get past it being a stigma, and the psychiatrists are looking for problems. If you don't have any, they will find them anyway. I mean, it's really true. We're trained to look for psychopathology. It's true. And so if the people aren't depressed when they came in, they're depressed when they walk out. Because you're focused on the negative. And then if you're not engaging and you're using those indirect techniques, you know, of dealing with the patient, so you're not that interactive, so the patient's out in front, and you're just saying, yeah, tell me more about that, yeah. Then the hour's over, and the patient walks out and says, what's wrong with him? Right? There's a cultural gap, whatever you want to call it, right? And they may interpret that as the doctor being cold and uncaring. You see, so if you want to change how you relate to people, Latinos, you may have to change the whole style of what you think is appropriate ways of interacting with patients, even the mental health professionals, because it may be inappropriate to the cultural group. But frequently we blame the people if they don't partake of the psychiatry or the psychological things that we have to offer. Remember too, there's a fear in black people with mental health issues, because they know from their experience, black people usually in all the southern states, but even here, even in New York City, when they got psychiatric help, it was usually that they were seriously ill and were sent to state hospitals. They were committed. So black people knew there were two officials in society who could lock you up against your will: cops and psychiatrists. Right? I mean, we would do outreach when I was working in this public housing development in Boston. You know it, Amanda, Columbia Point. We do this outreach, and nurses would go out, and if they found someone when they visit their home who was in emotional distress or depressed or something, they would come back and tell me. And then I would go out with them, and they would bring me into the home to talk to the person. So one day, this nurse brought me over to this black woman's house, said she was distressed and so on, and brought me with her, and she knocked on the door, and the woman said, who's there? And she said, well, so the nurse, and I have Dr. Poussaint with me. And she said, is he that there psychiatrist? And she said, yes. She said, he ain't coming in here. Now, she was probably had it right, because her experience living there, the experience she knew was psychiatrists came around to people, and somehow they ended up in a state hospital, and you never heard about them again. And she was going to protect herself against that possibility. So I wouldn't come in and find out somehow she's crazy, whatever it is, and put her in a state hospital, because outpatient treatment, see, that was such a big area of neglect, particularly when psychiatry was just growing and growing, of serving people. I mean, it's kind of a structural problem in psychiatry, because psychiatrists all went into private practice and wanted to deal with people who had money, so you could pay them. So you got the state hospital where the poor people were neglected. The fancy private hospitals is where you had all of the psychiatrists and the leading psychiatrists. There's all kinds of disparities in healthcare, but I want to leave maybe for the panel discussion. What do we do about these disparities? What are the issues? What do we have to do? What can our approach be to get rid of the slave deficit? And what do we do about the post-traumatic slavery syndrome? And finally, Even homicide is frequently an expression of depression and fatalism, which is high in the black community. And other self-destructive behaviors are frequently an expression of depression and lack of feelings of self-worth. So all of this connects in many, many different ways, and is very complicated across institutions, across communities, and within individual people themselves. Thank you.
Thank you, Dr. Poussaint, for those stimulating remarks and for providing us with such a rich historical context for our discussion. I'm Gene Washington. I'm the director of UCSF Medical Effectiveness Research Center for Diverse Populations, and I'm also a member of the board of directors of the California Healthcare Foundation. It's my pleasure to moderate this panel this evening, and it's also my pleasure to introduce our two panelists, Dr. Patricia Evans and Dr. Lavera Crawley. Dr. Patricia Evans is the medical director of the San Francisco Health Department's Program in Maternal and Child Health, and herself was a practicing physician in the African American community for many years. Dr. Lavera Crawley is based at Stanford's Biomedical Ethics Center, and she is the author of a recent report looking at trust, particularly as it relates to medical research. We're going to begin with some comments from Dr. Evans.
I must say that there are some very important and useful lessons that can be learned from the Tuskegee syphilis study, from that experiment. Even despite the anger that I feel, and I'm sure that many of you feel as well too, that arises when we think about what happened to those who were involved in that particular study and what was done and not done to them and for them, because that's a big issue that we all have to address. The out lies, the deceit, the total disregard for human dignity must never be forgotten. And I think that's one of the things that we have to do as a people is never forget. Because I find too often, we forgive and forget and move on, and we can't continue to do that. And that must be taken into account when we are developing systems that do work for us. What I do suggest is that each one of you obtain a copy of a very interesting paper entitled 20 Years of Follow-Up Experience in a Long-Range Medical Study by Eunice Rivers, who was a public health nurse involved in this particular study, that was written in Public Health Reports in 1953. It's a very interesting paper, and she talks about the non-medical aspects of that particular study. But I think that paper could be used to help develop a medical care system and research programs for African Americans, and should be looked upon perhaps as a blueprint for the development of these. Although this may anger some of you, because some of you may blame her also in terms of the Tuskegee syphilis study, there's some very good points that are brought up in that paper. And this was a 20-year follow-up, and for me, the most phenomenal thing was that they had an 87% return rate. 87% of the 600 people were able to be followed 20 years down the road. That's amazing to me. And some of the components of that paper that she discusses that I think that some of the things that we need to begin to look at happen to be, the first thing that they did was to hire somebody from the community, because she was from that community, she knew the community, she knew a lot of those families. The ones that she didn't know in the beginning, she certainly did get to know as well. And the other thing that she did too is that she helped to bridge the gap between those researchers. And sometimes, even I as a provider can make mistakes in terms of communication with patients. And sometimes somebody needs to interpret what I say to the patient as well, too. And that's exactly what she did. And she also assisted with the development of trust amongst these individuals, that they really trusted her. And then the other thing that was very pertinent was that it was a very holistic approach, because she not only dealt with the individual who was the research subject, but she dealt with the entire family because of her public health background. Recruitment strategies were quite interesting, because these are things that I've been talking about, for example, at the federal level at NIH, where you need to identify key leaders, which they did do, and they identified key black leaders and got them to buy off on that particular study. And then the recruitment also included this distribution of flyers and posters and things in the most common places that people went to: churches, community stores, and schools. Isn't that something that we do now? And something that we really do need to consider in terms of healthcare and also research? The other thing that was very important, I think, about this study, too, was the flexibility that was seen. They noted that they could not get these subjects to come back during planting time and harvesting time. So what they did was they went after the men during non-planting and non-harvesting times. They were flexible. And we need to become flexible and understand that we have to be flexible for African Americans in order to serve them appropriately. We have to be willing to go where the individual is. What is so sacrosanct about the clinic, the office, or the hospital that some of the procedures could not be done in the neighborhoods and, in fact, in the homes? Why is it that we always have to go someplace else to receive certain types of care? Does the blood pressure have to be taken only in the office, or can it be taken someplace else? I think if we do the above, we can make a real difference in terms of our respective communities' health improvement. Thank you very much.
I want to build on what Dr. Evans has just talked about and focus my comments on the implications of the historical events that happened at Tuskegee on medical research, and in particular, African American participation in research. But we can't talk about this subject without considering the impact of that legacy on what Dr. Poussaint raised in that whole issue of trust or distrust. My main point about the issue of trust in African Americans came from my reading of the medical and ethics literature on minority participation in research. This research often defers to this historical event, Tuskegee, and it makes such statements as, and I quote, "minorities lack trust," or they say that, quote, "we need to cultivate trust in African Americans," suggesting that the problem is dispositional, that there's something about the inherent disposition of blacks related to mistrust. I'll concede that this dispositional mistrust does exist among some of us, and as Dr. Poussaint has eloquently said, it's certainly justified. But the point I want to raise is that such an analysis may actually serve to promote an unfair portrayal of African Americans, identifying the locus of mistrust as existing within minorities, framing the issue as something that needs to be cultivated in them, unfairly shifts the burden away from the perpetrators and onto the victim. And furthermore, situating problems associated with trust outside of a more local institutional context, again referring to something that happened in the past, fails to recognize the influence of the here and now. Clinical encounters where patients directly experience actual untrustworthy situations, the many examples that Dr. Poussaint gave us, that's more likely to affect whether or not an African American is going to participate in a clinical trial than they're thinking about some historical event. If we want to improve minority participation in research, investigators must pay close attention to all the factors related to trust and their own trustworthiness, rather than locating the source of mistrust, as I've said, within minorities. I believe a more equitable stance would include reframing the problem as a breach of trust. This invites researchers to search for sources of untrustworthiness among their own practices and behaviors, as well as within their institutional structures. And research itself that serves to improve the health of minority individuals and communities will generally meet the standards of credibility. But those poorly designed studies, as the Tuskegee study was, those that are designed to reinforce negative or outdated notions of race or biological differences, not only match the criteria of being untrustworthy, but they're also potentially dangerous in their capacity to perpetuate negative stereotypes. Finally, I think that research needs to be conducted always in a manner that conveys humanistic concerns, including compassion.